Good evening, everyone. For those who are joining now, today is a very special day because we have a very good topic that we'll be discussing. And today's topic is an overview of renal involvement in HIV. So my name is Egina Francis Makwabe, and I would like to welcome you all into today's AHN Nephrology webinar. And today I have a great honor to introduce to you a very special speaker who is not her first time to be with us. And it's a great honor to introduce to you Professor Salaradevi Naicker. Professor Naicker is Emeritus Professor of Medicine and former Chair of Graduate Studies and Research, Plagiarism and Mentorship Committee of the School of Clinical Medicine at the University of Wits in Johannesburg, South Africa. She's also a former academic head, Department of Internal Medicine and Division of Nephrology at Wits University, head of Division of Nephrology at the University of KwaZulu, Natal in 1994 to 2001. Professor Naicker is the president of the South African Renal Society in 1994 to 1997, and later to 2012 to 2015, and president of the South African Transplantation Society, and also chaired the South African Ministerial Advisory Committee for Transplantation. She's a member of the Executive Council of African Association of Nephrology from 2012 to present, and the Executive Council of the African Nephrology Society, 2012 to present. And Professor Naicker served on ISN Council in 2005 to 2011, and Executive Committee and ISPD Council, and chaired the following committees: ISPD Fellowship Committee and Awards Committee, the ISN Africa Regional Committee, ISN Education Ambassadors Program, and the ISN Nominating Committee, 2018 to 2019. She was a member of KDIGO Executive Committee and co-chaired the DICG Professional Society Working Group, 2009 to 2013. She has supervised a large number of postgraduate students at master's and PhD levels, and has published 17 book chapters and approximately 180 publications in peer-reviewed journals. She has several awards, which includes recipient of ISN Roski Robinson Awards, International Distinguished Medal of the NFK, this National Kidney Foundation, South USA, Convocation Philip Tobias Distinguished Teaching Award of the University of Wits, Exceptional Service Medal, Faculty of Health Science, University of Wits, Best Postgraduate Supervisor Award, Wits Faculty of Health Science, and Honorary Life Membership of South African Renal Society. It's a great honor to present to you and to introduce to you and welcome Professor Naicker. Professor Naicker, you are warmly welcome.
Thank you very much, Ekina, for that very warm welcome. Good afternoon, good evening, colleagues and friends. It's a real pleasure to be with you again today. And I'll just hopefully be able to share my slides at this point. Can you see these?
Yeah.
Yes.
Great, thank you very much. Just to say that I have no conflicts to disclose, and I'm going to talk on some of these topics today, looking at the patterns of kidney disease with HIV, the impact of antiretroviral therapy, nephrotoxicity of antiretroviral therapy, and some brief aspects of genetics on HIV chronic kidney disease, and the importance of screening, early diagnosis, and treatment. looking at an overview, one really needs to be aware of the spectrum of kidney disease and HIV infection. And it's a very vast and broad topic, and time does not allow me to go into too many of them. So I'm not going to talk at all on electrolyte and acid-base disturbances or acute kidney injury. So I'm basically going to confine myself to chronic kidney disease and talk about some of the side effects related to treatment. Importantly, to say that when we first started engaging in HIV kidney disease, it was amazing to see patients coming in with very severe kidney dysfunction, with serum creatinines of 1,500, etc. And it seemed at the outset that these patients had chronic kidney disease, but often with supportive treatment, lots of fluid replacement, occasionally acute dialysis, a lot of patients recovered completely. So we learned that one shouldn't just look at a patient, just say this is chronic kidney disease. And even if you didn't have dialysis therapies, to just fold your hands and say there's nothing that can be done. So one needs to give the best supportive care and see if you could reverse the kidney dysfunction and have patients having normal kidney function thereafter. So that was an important lesson early on in our adventures with HIV kidney disease. This slide that I've taken is from the KDIGO Controversies Conference on HIV and kidney disease that was held by KDIGO in Cameroon in 2018. And this was an international conference with a lot of African representation. So this is a very good composite of that conference, which looked at risk factors and underlying CKD etiology in HIV, chronic kidney disease. So looking at the very left, looking at the host genetic susceptibilities, I think we're all very aware of the role of ApoL1 high-risk variants. And sickle cell trait is thought to contribute in some way to the outcomes of chronic kidney disease. And then the ABCC2-4 variants, which are thought to play a role in Tenofovir toxicity. So all these impact on the socio-demographic background of the patients, where age is important, ethnicity is very important. And this is particularly in its expression of the type of kidney disease, and I'll go into this further, where we know that HIVAN occurs almost predominantly in people of African ethnicity, whereas other forms of disease, for instance, immune complex disease, are seen more often in Asian and white populations. And then other hits such as illicit drug use, poor socioeconomic status, all impact on both the expression of disease and the frequency of disease. And other comorbid conditions also impact on kidney disease. And these are the common ones that we're all aware of, such as diabetes, obesity, hypertension, cardiovascular disease, etc. And not to forget traditional herbal medications. And the important aspect is to look at the HIV-related factors. Quite often, kidney disease occurs in the presence of a high viral load, low CD4 count, and I'll go into this further, where a lot of patients with HIV-associated nephropathy tend to have very low CD4 counts, under 200. And then, of course, the initiation of antiretroviral therapy has been shown to impact and change the disease expression and the form of kidney histology nowadays. And of course, in our environment, Co-infections are important. Hepatitis, both B and C are important. Tuberculosis, parasites, syphilis, etc. So basically, when we're looking at a patient with HIV with chronic kidney disease, we think that all patients have IVAN, not necessarily so, or focal segmental glomerulosclerosis, or FSGS for short, immune complex disease, and there are a host of other diseases which I will talk about shortly. The presentation of patients with kidney disease, chronic kidney disease with HIV, is very similar. So if you have a patient with proteinuria or albuminuria or nephrotic syndrome, who invariably has varying degrees of kidney dysfunction, it's difficult to say what the patient has histologically. And often that's why most nephrologists would like to do a kidney biopsy. And looking at the prevalence of chronic kidney disease in South Africa, in population-based studies, we found that this can occur in up to 8% of patients with HIV. And if you translate the millions of patients in sub-Saharan Africa with the HIV infection, you could see the number of people who are potentially walking around with chronic kidney disease. This again goes back to the KDIGO Controversies Conference, where the Pathology Working Group, again, a very international group of experienced and renowned pathologists, worked on the pathological classification of HIV chronic kidney disease, and they divided it into glomerular dominant, and these were the podocytopathies, and these are the various glomerular diseases like classic HIVAN, FSGS, minimal change disease, etc. Or immune complex mediated disease, and this list subtypes on the right shows the various types of immune complex disease, IgA, lupus, membranous, etc. And then there may be some patients who do not have much in the way of glomerular disease, but have tubular interstitial dominant disease. And this could be tubular interstitial injury or acute necrosis. This could be due to direct infection by the HIV virus or immunologically mediated or drug-induced. And then the vascular dominant type, thrombotic microangiopathy, arteriosclerosis. And then in the setting of HIV, one would often find diabetic nephropathy and age or hypertension-related nephrosclerosis. Now, these old studies are quite interesting, but of historical interest now, because when I started working in this field, it seemed that most patients, this is one of our first studies in Durban, where over 80% of patients had HIVAN. And if you look at other South African studies, the prevalence of HIVAN changed depending on the era. This was in the early 2000s. A decade later, of HIVAN changed, ranging between 15 to 27%. And then similarly, in the early period in Cape Town, HIVAN occurred in over 50% of patients. And in Nigeria, where of the first 10 biopsies, 7 out of 10 had HIVAN. And there was a range of the other pathologies like immune complex disease, FSGS, etc. Just to remind everybody what HIVAN looks like, this picture is a very classic view showing the collapsed glomerulus. So you have the collapsing glomerulopathy, the focal sclerosing lesions, and the very dilated tubules, the microcystic tubular dilatation, and the interstitial inflammation. So basically with HIVAN, every compartment of the kidney is involved. And looking at electron microscopy, one could see the tubular reticular inclusions, glomerular endothelial cells, which is thought to be due to gamma interferon activation in the kidney. Now, what about kidney histology in the modern era? This recent study in Kidney International reviewed 437 biopsies from HIV-infected patients from a biopsy database of over 26,000 biopsies in the last decade. Interestingly, when one looks at this, over 80% of patients were on antiretroviral therapy, and over 60% were male. And looking at ethnicity, again, majority of Black ethnicity, and there was a fair number of comorbid conditions such as diabetes in over 30%, hypertension over 50%, and over a quarter had hepatitis C co-infection. Now, when we look at the biopsy breakdown in this population, you could see that HIVAN still occurs, but has taken third place. Immune complex disease was the number one, and followed by diabetes, and then Tenofovir toxicity and FSGS. So the conclusion in this very interesting paper is that antiretroviral therapy has changed the landscape of HIV-associated kidney disease towards diverse immune complex glomerular diseases, diabetic nephropathy, and non-collapsing glomerulosclerosis. But HIVAN has not been eradicated. So the question is there a need for kidney biopsy now that antiretroviral therapy is almost freely available? If you speak to most nephrologists, they would say that it's very important to have an accurate histological diagnosis so that you could give specific treatment. For instance, specific immune complex diseases may need specific immunosuppressives, and also to prognosticate. And I'll talk further later on about the prognosis. And what about biomarkers? I know that Professor Bima's group has also done some work looking at biomarkers and their correlation with kidney histology, especially HIVAN. And the biomarkers listed here, KIM1, FABP, alpha-1 microglobulin, beta-2 microglobulin, NAG, etc., NGAL, have all been shown to be elevated in the urine of patients with kidney disease. But looking at biopsy-proven HIVAN, it's been shown that there have been high levels of beta-2 microglobulin, FGF2, metalloproteinase 2, and low levels of EGF in children with HIVAN. And more interestingly is NGAL. Studies have shown that NGAL has been excreted in larger amounts in adults. And our own study, which is in press currently, showed that there was increased levels of serum and urinary NGAL in HIVAN with increased urinary TGF-beta-1 and beta-2, whereas beta-3 did not show the same change. Unfortunately, by the time one got to the subgroup analysis, the study was not powered to give a cutoff level for NGAL. It would be interesting if this could be done in future, to look at this in a larger cohort. And looking at biomarkers in disease progression and death, increased levels of urinary albumin, alpha-1 microglobulin, interleukin-18, and KIM levels were associated with faster GFR decline in the women's study of HIV infection. And FABP showed that there was a J-shaped association with death. So that was a very interesting finding as well. So biomarkers seem to have some role in correlation with histological subtypes, but I think that we need to have large national and perhaps international studies to really have large patient numbers so that the studies are adequately powered to give definitive answers to these questions. What about the genetics? Initially, MYH9 on chromosome 22 was thought to be very important in HIV kidney disease, but functional studies showed that it was actually the ApoL1 gene, which is further downstream on the same chromosome. And this gene was shown to code for the apolipoprotein L1 protein, and initially developed developed in evolution. It had tripasomal lysis, and developed in West Africa to try and protect populations against sleeping sickness or trypanosomiasis. And it resulted in autophagic cell death and was important in lipid metabolism. So these populations who survived trypanosomiasis seem to have an increased predisposition to kidney disease. And with the slave trade, this gene was transported worldwide. And looking at some studies of ApoL1 and CKD in general, in hypertension, studies showed that there was an association with hypertension per se, with an odds ratio of 7. In the African American study of kidney disease, there was a 2.57 odds ratio, which increased to over 6 in advanced CKD. This association was even stronger with FSGS, and even much stronger with HIVAN. In the American study, an odds ratio of 29. In our study, this was the highest odds ratio of 89, where 79% of our patients with HIVAN were shown to have L1 high-risk genotypes. And in children, it was shown that there was 3-fold increased odds of CKD with the high-risk genotype. That kids with the high-risk genotype manifested with kidney disease at an earlier median age of 8.8 compared to 14 with those without the high-risk genotype. It's also associated with lupus nephropathy and sickle cell nephropathy. And looking at whether ApoL1 impacts on the response to treatment, studies have shown that there's been a rapid progression of HIVAN to end-stage kidney disease if there was no treatment or if treatment was not appropriately given. And there was a 3-fold increase risk of end-stage kidney disease in non-HIVAN in spite of effective therapy with antiretroviral therapy and RAS blockade. Interesting study also showed the association of ApoL1 with viral suppression. So there was a 2.5-fold decline in EGFR with the high-risk genotype if there was poor viral suppression. And this study by Estrella shows that where patients were not adequately virally suppressed, that over time their kidney function declined much more rapidly than those who were virally suppressed. This slide shows the prevalence of high-risk ApoL1 genotypes in patients with kidney disease in both African American and Black South Africans. And this shows that the population controls in South Africa, the high-risk genotype occurred in our study in 3% of the population. And looking at HIVAN, as I mentioned, 79%, whereas African Americans with HIVAN, the high-risk genotype occurred in 60 to 70%. And this shows the risk of HIVAN or FSGS by the number of high-risk alleles. So it shows that the highest risk with HIVAN and FSGS occurs in the presence of two-risk alleles, which is the high-risk genotype. Whereas if there are no risk alleles, one could see that the prevalence of HIVAN and FSGS is actually much, much lower. So what mediates ApoL1 cytotoxicity? Both the G1 and G2 alleles increase intracellular loss of potassium early on, and this activates MAP kinase pathways and acts as a mediator of cell death. And these actually depend on the penetrance of these genes. And this cartoon shows the extrusion of potassium from the cell. And this results in cytotoxicity via the MAP kinase pathway by causing cytoplasm swelling and autophagy.
Yeah.
And looking further into the mechanism of kidney disease, one could see that ApoL1 high-risk variants may cause glomerulosclerosis, and these mutated particles bind less tightly to the circulating HDL3 and undergo glomerular filtration, tubular reabsorption, and cause mesangial proliferation and fluorosis. And endogenous ApoL1 within the renal epithelium may cause apoptosis and cell death thereby. This cartoon is very interesting in that it shows that while one may have the high-risk ApoL1 genotype, one needs second hits, the modifying factors, which could be the virus itself, such as HIV virus or hepatitis viruses, the presence or absence of antiretroviral therapy, presence of polyomavirus, which may be protective in these populations, and second gene abnormalities such as NEPHIS2, BMP4, and then disease. The disease expression could be variable, such as FSGS, HIVAN, sickle cell, or lupus nephropathy. So this is the postulate made by Friedman and Skorecki and still holds water. Now looking at tenofovir toxicity briefly, tenofovir is in all of our first-line therapies currently, and the renal toxicity could be either acute kidney injury, chronic kidney disease, and I think what is vastly underestimated is the extent of proximal tubular injury, which could be Fanconi syndrome, which is manifested with hyperphosphatemia, hyperphosphaturia, acidosis, glycosuria, and hypokalemia. And one could have isolated hypophosphatemia and decreased bone mineral density in these patients. The patients at risk are generally those of older age, lower body weight, those who have pre-existing renal dysfunction before initiation of tenofovir, and lower CD4 count with comorbid disease such as diabetes, hypertension, hepatitis C, and of course concurrent use of nephrotoxic drugs or protease inhibitors were predisposed to it, and also a genetic predisposition. Various studies have shown the degree of nephrotoxicity. A meta-analysis that we did almost 10 years ago showed that there was a small but significant loss of kidney function of just under 4 mL per minute per year. And a large cohort study showed an increase in serum creatinine of just over 0.5 milligram per deciliter in over 2% of patients, and over 2 milligrams per deciliter in 0.6%. our own study in Johannesburg in over 800 patients, where we looked at outcomes at 48 months. Nephrotoxicity occurred in 2.4% of patients at a median of 3.6 months, with death in 7.8% of this cohort. And this cartoon shows you the pictures of Tenofovir nephrotoxicity, with the first picture on the top left showing the very flattened tubular epithelium. And this is a classic picture of acute tubular necrosis, whereas this shows you more chronic tubular interstitial nephritis with tubular atrophy and interstitial fibrosis. This shows the eosinophilic inclusions, low power, higher power, which is classic of Tenofovir nephrotoxicity, and the electron micrographs showing the mitochondrial changes that one sees with giant mitochondria, with loss of Christie, and the very diverse, irregular mitochondria. So this is a classic picture on electron microscopy. What about the newer variant, Tenofovir meliflunomide or TAF? This has comparable efficacy, but about half the nephrotoxicity. And the bone effects are also thought to be lower, to be less than those of TDF. So these recommendations from the KDIGO conference suggest that one should perform risk stratification into whether your patient is low risk or high risk before starting antiretroviral therapy. So this shows the low risk population with preserved kidney function, minimal proteinuria, a younger population under 50, and one would give standard antiretroviral therapy according to local guideline. High risk with kidney dysfunction, more proteinuria, older age group with various comorbidities. And here one needs to individualize treatment and try and avoid nephrotoxic therapies in these patients. And we'll discuss further how one should do this. And in patients with kidney disease, it's recommended that one gives renin-angiotensin blockade. And this study, almost a decade old now, shows the better kidney outcomes in patients who received renin-angiotensin blockers over 100 months, whereas those who didn't had a much more rapid kidney decline. What about dialysis? As far as hemodialysis goes, there's no need for routine isolation of patients or machines according to the CDC recommendations, where standard virucidal agents are effective in sterilizing machines. Infection control measures are important, and patient survival. This is an old study showing the 1-year survival in Europe and the US, whereas in the early days before effective antiretroviral therapy, the 5-year survival was not so good. There's some possibility to increase graft infection and thrombosis. And in fact, some studies also said that one could reuse dialysis in HIV infected patients, but very few people are instituting reuse of dialysis in HIV infected patients. And looking at PD, in PD, one needs to be aware that the virus survives for up to 7 days in the PD effluent and for 48 hours in dry tubing. And therefore, patients need to be taught how to handle this problem. And both bleach and amikin are virucidal. It's important to try and initiate PD with CD4 counts above 200, because if that's done, peritonitis rates are very similar to the non-HIV populations. And improved survival on dialysis is associated with earlier initiation of both antiretroviral therapy and renal replacement therapy with younger age and higher CD4 counts. This study in Johannesburg looked at survival of HIV positive and HIV negative populations. And basically, the study showed that there was a very similar survival in spite of suboptimal viral suppression. And the only difference was that patients had a higher incidence of tuberculosis, whereas all other complications seem to be very similar and outcomes similar. So kidney transplantation should be considered for any end-stage kidney patient who's medically fit with a life expectancy of at least 5 years. And there are specific HIV inclusion criteria: a CD4 count of more than 200 cells per microliter for at least 6 months, undetectable viremia, absence of AIDS-defining disease, and the patient needs to demonstrate adherence and be stable on an antiretroviral regimen for at least 6 months. And ART needs to be available in the future while the patient has been transplanted. This is one of the larger transplant series that Stock published in the NEJM following an NIH trial where he reported on 150 patients. And on the left, you see the antiretroviral therapy that was used, as well as the immunosuppression. Interestingly, you see that the vast majority had induction therapy of some form. They were all on calcineurin inhibitors, and a vast majority on mycophenolate mofetil. And looking at patient survival at 1 year and 3 years, it's very similar to the non-HIV population, and graft survival similar. The one thing, though, was that they showed a significant amount of acute rejection at 1 year and 3 years, 31.1%. There was a very small number who had HIV disease progression while on transplantation. And this shows the HIV population patient survival, which is very similar to the whole cohort, and significantly better than the older age group. And this shows graft survival, which is similar. And a recent meta-analysis looking at 1,670 transplants in HIV positive recipients. The study showed the 1 year and 3 year patient survival of over 90% and graft survival of 91% at 1 year and 81% at 3 years. And 41% had a range of infections, and acute rejection was present in 33% in the first year. And then what about the HIV positive donor kidneys to HIV positive recipients? The largest series is from Cape Town, and this more recent update by Elmi Muller's group showed that 51 of these transplants followed for 5 years. So the top line shows the patient survival over 5 years, starting at 87 at 1 year, 84 at 5 years, graft survival 96 at 1 year, 79% at 5 years, and the number that did not have rejection over the same period. So only about 25% rejection in the first year. So I thought that these days when one gives any talk, one needs to also look at whether COVID impacts. So while I could not find any studies looking at HIV kidney disease and what happens in the presence of COVID, but certainly when one looks at mortality in people with HIV, one can see that there's an overall increased risk ratio of 1.78. And this shows various studies in the USA, UK, South Africa of the mortality rate in HIV infected populations. And looking at the comorbidities and risks in these populations, as one knows, patients with diabetes probably have the highest risk, followed by CKD, 76%, double risk in patients with TB, and a 31% increased risk of hypertensive populations. And again, looking at the risk of death in this series, there's a 2.59 increase hazards risk, and also almost a double or more than a double risk in Black populations compared to non-Black populations. And the risk increase in elderly, obese, Black, Asian, and people with comorbidity, and those with CD4 counts under 200. This KDIGO recommendation for screening suggests that one at the outset one should screen patients for kidney disease by looking at the estimated GFR and looking at proteinuria. And if they're low risk, one should monitor them annually. And if they're high risk, at least twice yearly. And as far as nephrology referral goes, those with unexplained AKI or CKD, or with rapid kidney function decline, new onset or worsening proteinuria, CKD stage 3B or 4, need to be evaluated for kidney replacement therapy and evaluation. And this summarizes that how one should manage these patients. Early diagnosis and screening, as mentioned, by screening for proteinuria and kidney function, bearing in mind the high-risk populations, Black populations, those with low CD4 counts, high viral loads, those with comorbidity, those with the first or second degree relative with the end-stage kidney disease, where the risk is increased more than 5-fold. And then as far as corticosteroids go, one should give antiretroviral therapy and RAS blockade to practically all patients, and steroids for those with prominent interstitial inflammation, immune complex disease, those with rapidly progressive disease. And CKD management should be similar to those with any other patient, except that one needs to be aware of dose adjusting according to the GFR. I'm not going to go into this in any great detail, except to say that one needs to be aware of using tenofovir or dosage of tenofovir according to the patient's kidney function. The GFR is equal to or less than 50. One needs to probably give it once a day. It's between 30 and 49 mils per minute, probably every 48 hours. And then if it's lower than 30, one needs to be very wary and probably use alternative treatment. I will make these slides available, and this is a very useful chart from the European clinicians group, which looks at most of the current drugs and how you should dose adjust according to the different levels of GFR. And yeah, so this goes into this further. And I will just end up by saying what the South African HIV Clinician Society guidelines are. So for patients on chronic hemodialysis, they advocate that one should use abacavir, 3TC, and dolutegravir at these doses. And on the days when dialysis is performed, the drugs should be given after dialysis. And one needs to be very wary of tenofovir, but if necessary, one should only use it once a week. Try to avoid AZT because of its association of anemia in patients with kidney failure. And then concluding, I just would like to thank all my colleagues at Wits, at UKZN, and our international colleagues, especially Jeffrey Kopp, Cheryl Winkler, and George Nelson, who assisted us with our various studies in HIV nephropathy. Thank you very much for your attention. I'm happy to answer any questions.
Thank you very much, Professor Naicker. That was excellent talk. Yeah, and it's a time for question and answers and comments. Professor Naicker, how long does it take for a patient who is on ARV to develop, specifically tenofovir, to develop the toxicity? Because I have seen some patients starting tenofovir for a couple of years, then later they develop toxicity to tenofovir. Yes.
Yes, in our study in Johannesburg, we showed that it occurred at a median of 4 months. So it seems that one really needs to monitor them at all stages. If you have a high-risk group, you should actually monitor for proximal tubular dysfunction. In fact, a colleague of mine is actually doing a study in Nigeria where he's been monitoring it, and we're still analyzing the data at the moment. So perhaps you should just wait for that to see, because this is a prospective study that he's doing, whereas most retrospective studies says that it occurs early and it can occur at a median time of 3 to 4 months.
Thank you,
whereas
Prof.
chronic changes could occur at any stage later on.
All right. Thank you, Prof. I've seen the hand from Prof. Sabima, and then Johnny Ngobi. Prof. Sabima.
Thank you very much, Ijana. Salah, thank you very much for that lovely talk. I know time constraints don't permit you to go into great detail, but I just want to bring up that there's some differences between the expression of HIV in children as opposed to adults. You know, while in adults you were seeing in the early phase of disease a lot of collapsing FSGS, we didn't see it. And I was very surprised when we looked at our biopsy cohort and we only saw FSGS not otherwise specified. And we saw a small percentage of HIV, but not any great thing to shout about. So that was one difference that we saw. And this was in the early phase, you know, in the early 2000s. The next thing was that, you know, the study you did on the APOL1 gene, we replicated the study in pediatrics, but it was a smaller number of patients, but I must say it didn't come out significant. So it seems that the expression of the gene varies between, you know, the early phase and age has a major impact as opposed to what you see in adults. Then the next thing was that impact of treatment, etc. Sorry, I didn't put my video on because we are load shedding, so I can't get signal. So the impression, the impact of tenofovir was not so pronounced in childhood as opposed to adult. But then remember, the HIV Clinicians Association didn't use tenofovir in the early phase of the disease, so I can't tell you what happened earlier on. You understand? So we didn't see that picture, and I must say toxicity was pretty rare, even in those patients we use it, whether with HIV-related kidney disease or outside of that in HIV-positive patients. So it looks like pediatric HIV is slightly different, and even the immune complex-mediated disease, which now is the highest in adults, we didn't see that. You know, we just saw classical FSGS. So it seems that there are distinct differences, and the APOL1 gene doesn't seem to play a big role in the pediatric population. Thanks, sir.
No, you're absolutely correct. I should have said upfront that I was talking about adults as an adult nephrologist.
No.
And I know that you and I had lots of discussions about what constitutes HIVAN in children.
Yes, yes.
Because I know HIVAN in children, if you have FSGS, that equates HIVAN, whereas in adults, we sort of, in fact, the KDIGO conference also said that in adults, you need classic HIVAN to say that HIV is the etiology of this lesion. So they distinguish between classic collapsing FSGS with tubular changes from the FSGS lesion. So these were totally separate. And then to add to what we are seeing currently, so when we embarked on prospective studies of HIVAN, I must tell you, if you want to have a disease disappear, you must just embark on a study. And we just could not find these large numbers of HIVAN that we found initially. So in fact, one of my colleagues has recently, just this week actually, submitted a paper where we looked at over 500 kidney biopsies in Johannesburg in patients with HIVAN. And if you look at the two eras before antiretroviral therapy, where there was a lot of HIVAN, and subsequently, and you can see that in subsequent years, we are seeing more FSGS and immune complex disease than HIVAN. And I think what you said about ApoL1 is very interesting. And I think it's something that we still need to know a lot more about its functional role, the impact of age, the impact of, other second hits. Yeah. And perhaps one of the things about kids is that, that they, while they may have the gene, they probably, the genetic expression is not as severe in adults. Maybe time has something to say, but I think they're a very interesting thing. And I think in Africa, I keep saying that I think we've got such a wealth of patience and talent. We really should embark on multi-country studies and we can answer all these questions, don't you think?
Yeah, I must say, Salo, you're absolutely right. You embark on a study and the disease disappears. In the present state at Albert Utrecht, where we have all the referrals of patients with kidney disease, I haven't seen in the last 3 years more than 2 cases of HIV-associated kidney disease. Well, the prevention program is almost disappeared. And so, we've lost that. It's great for the patient, not good for us. See, but thank you so much. Thanks, Jana.
But we're still seeing a lot of HIV kidney disease, I must say, in adults. Yeah. And a lot of them are still treatment naive, sad to say, even though treatment is readily available and freely available, people don't seem to avail themselves of it.
Thank you, Prof. Thank you very much, Bima and Prof. There is a hand from John Mumbi. John?
Yes. Good evening, everyone. Hello, can you hear me?
Hello. Yes, John, please.
Thank you, Professor, for that wonderful presentation. I'm speaking from Mbarara University in Uganda. I'm interested about the Tenofovir side effect as well. You have highlighted about the underreporting of the Tenofovir toxicity as a cause of tubulopathy, which present as a Fanconi syndrome, and its presentation or risk of the patient to develop bone disease. So we have several studies, one in Obiebi et al. In 2018 from Nigeria, who follow up the patient for 6 months from the baseline then to 6 months and report significant phosphate, urinary phosphate wasting and uric acid, as well as there are other studies in Netherlands, in Pablo et al. And as well as in Spain, which they use these parameters of Fanconi syndrome to try to screen or diagnose the tubulopathy. My question are, what are the sensitivity of these parameters of Fanconi syndrome when you are using them to diagnose the TDF tubulopathy? And the second is, why aren't we using these parameters or they're not incorporated in our guidelines, Africa guidelines for screening of tubulopathy. Instead, we are keep on looking at drop of the EGFR in these patients, while we have the tubulopathy can happen even in a patient who has normal renal function in terms of EGFR. Thank you.
Thank you, John. I think you've made some very important and very significant points there. And I think one of the difficulties is to see that, laboratory services, even in South Africa, you don't find that every patient has kidney function measured. I mean, a serum creatinine before initiation of antiretroviral therapy, for instance, even though that's supposed to be standard of care. So having said that, looking at proximal tubular function, even simple things like glycosuria, which can be easily done, or phosphaturia, just has not got to standard of care. And in fact, I'd read some studies where in defense of not doing laboratory testing, the feeling was that the prevalence of nephrotoxicity was so low that it really didn't matter. You should just treat everybody. And if somebody ran into trouble, then you dealt with it. I'm not sure that you and I would agree with that. So the question is, what does the proximal tubular dysfunction translate to over time? I think when one sees, it's a personal belief, and I've got no data for this. And if you have any data, it'll be interesting to hear from you and others on the webinar, is that my belief is that tubular dysfunction is an early stage of nephrotoxicity. And if one ignores it and continues, one would then go on to chronic tubular dysfunction and chronic kidney disease. That's my belief. And so therefore, I think while one can't advocate full screening in everybody, but in high-risk people, if you want to use tenofovir, then I think these are the people you need to screen, every few months. When you start your tenofovir, then perhaps at 2 months or 3 months, one needs to screen for proximal tubular dysfunction.
All right, thank you, Prof. Thank you very much. Thank you, John, for the very good question. We still have a couple of minutes for more questions and comments.
Sorry if I can jump in a bit.
Yes, John.
Yes. So this question of the repercussion of TDF toxicity in maybe a patient who has a normal renal function, it's a common question, but there have been studies that they report irreversibility of these patients upon follow-up. So like more than 50%, I think it was done by Weaver et al., not to remember the country, in 2010, they follow up the patients who are confirmed to have TDF tubulopathy, and these patients, some of 50% of them reverse back to their normal renal function, but 50% after 2 years they did not revert it back. And this again, I think the tubulopathy is just the first presentation, but Shiva et al. in US, he reported that actually many patients, they progress, like there is an increase of about 33% or risk of developing CKD when a patient is put in on TDF use for 1 year. So each 1 year, you have risk of increase of 33%. And this was a large cohort study that was done in US. There is another one that I think it was done in South Africa and in US as well, of recent, that report the issue of the bone density effect using DEXA. So I think we are looking at TDF in a way that we want the nephrotoxicity, to be presented as as a drop of the EGFR or raise of the creatinine, which is the very, very late marker for this effect. Maybe I stand to be corrected. Maybe we should look in other way around and see if we can do more studies to understand the part of the tubulopathy.
Because what happens with people with tubulopathy, they would have a lot, if they go on for a long time, they would end up with chronic tubular interstitial nephritis. And then while the GFR is preserved till a late stage, what happens later on is that there's secondary glomerulosclerosis. So it's quite important when one sees, say, a glomerulosclerosing lesion, you know, whether this is a primary FSGS lesion or a secondary, you know, FSGS. So I think this would be like a secondary FSGS and not the primary FSGS of HIV. So a lot of adults whom we biopsy and end up with this sort of thing perhaps have had chronic tubulopathy, but we don't know because we see them at a late stage once they're in advanced kidney disease, and you biopsy them and you see all these sclerosed glomeruli.
Thank you, Professor. Thank you so much. I think that's it for me.
Thank you, Prof.
Thank you very much. Yeah.
Yeah. Any other comments, questions? I'll allow two more questions.
One question in the chat box. One question in the chat box.
Okay, Professor, can you read that question, or I should read it for you, Prof?
See, I've just put it on now. So this is a patient who was on HIV positive, was on hemodialysis once a month. And now off dialysis, but still has an elevated serum creatinine. Difficult to say with just the data that's there. One would want to know other things like what's the blood pressure doing, what's the level of proteinuria. And this is sort of patient one wants to know whether he's had acute on chronic renal failure. You know, the fact that he's had very sort of transient and episodic dialysis and has improved. So the fact that this patient still has kidney dysfunction, I would actually biopsy him, because I think anything else would be a guess, because he really has unexplained kidney failure. And that's one of the reasons to do a kidney biopsy. I see there's another question on massive proteinuria, ACE inhibition. I think here one needs to know what the lesion is. Is this a membranous nephropathy, or what is it, you know, causing the proteinuria? Because if it's a membranous lesion, then one would treat it like you would treat any other primary membranous nephropathy with immunosuppression, as well as ACE inhibitors. Yeah. So again, as you see, I'm a big advocate of biopsies, that you need to know what you're dealing with so that you can deal with the situation properly, adequately. Having said that, sometimes it can be very, very difficult to get on top of massive proteinuria, and that's really a poor prognostic sign. But one needs to optimize all antiproteinuric therapies in such patients.
All right.
Yes, one question.
Yes.
One question.
Yes.
Thank you very much, Dr. Naicker. Wonderful presentation. I hope you'll share the slides with us. I'll send it across to everybody, whoever we have on our database. It's
Sure.
a wonderful slides and a lot of information. The one thing, I think it's about 2010 or 2011 when I was involved with a few HIV transplants in India. And one of the major challenges that we had at that point in time was the calcineurin inhibitors interacting with the ART that we use post-transplant. So what do you do now? It's a while since I've gone off HIV transplant. So what do you do now with them? What are the ARTs that you use now? And is calcineurin still a big challenge in maintaining the levels post-transplant? Or you have new antiviral retrovirals come on now?
currently they're still using standard immunosuppression with tacrolimus, but the doses are so minuscule, compared to people who are not on antiretroviral therapy. So we find like the first 2 weeks of an HIV positive recipient, quite challenging because you have to actually monitor them very intensively, start them on very low doses of, or maintain them on very low doses of tacrolimus, and try and get your blood levels, trough levels right before you send them off home. So we do quite intensive monitoring in the first 2 weeks.
And the other thing I remember was the use of mycophenolate was thought to be protective. It had some protective effect in HIV post-transplant, and it's an immunosuppressant. I don't remember the reason actually. There was something to that.
No, we tended to give induction treatment and use tacrolimus and MMF simply to try and sort of minimize the episodes of early acute rejection, because a combination of your CNI and MMF is quite a good, very effective immunosuppression in decreasing the incidence of acute rejection. We did read about the sort of protective effect, but I haven't seen it sort of discussed further. So I'm not sure if there's anything further on it.
The other last thing was, I think that there used to be at that time, I think there was an NEGM paper that showed that there was a very big difference between survival on dialysis and survival on transplant. The survival on transplant was far higher than on dialysis. Actually, the mortality is much higher, or the shorter survival on dialysis.
Yes, I think that was probably the more of that data was in the pre-antiretroviral era. In our recent study in Johannesburg, where my colleague June Fabian looked at all the HIV positive patients in 2 institutions, the outcomes were actually very similar to the non-HIV hemodialysis patients.
Okay.
And another colleague had done a PD study and actually hasn't published it, and again found that there was not much of a difference in patients on PD with HIV as well.
Sorry, can I just answer Lloyd's question about MMF and its impact on HIV? Actually, you are right, Lloyd. The MMF is the ionosine monophosphate dehydrogenase inhibitor. So it has a direct effect on HIV replication as such. And it's been shown in 2 papers that when you use MMF in transplant, etc., it does inhibit the HIV replication. So it does have some effect on the disease itself. So you are right. It is definitely something that it's not as good as antiretrovirals, but it does have some effect. And CNIs have also been shown to be quite useful in that respect. But of course, we don't use them as antiretrovirals. Okay.
So having said that, initially we were quite interested in Elmi Muller's study, on HIV positive donor kidneys to HIV positive recipients, to see what happened to the recipients afterwards. Did they develop HIV kidney disease? In the first few years, there weren't, but subsequently, there were a few cases of HIVAN in her series. So it appeared that even though you were giving your patients state-of-the-art treatment, it really didn't make that much of a difference. And I think she's also in the process of studying the genetics, because what are the genotypes that might result in this sort of disease progression? Because they were also doing implant biopsies, looking at whether you are transmitting diseased kidneys to the recipients. And that was not the case. Yeah.
And what has been, I don't know now, but do you all transplant HIV positive kidneys from donors HIV positive to HIV patients, recipients who are HIV positive as well? And what are the outcomes there?
Well, as I said, the largest series was the Cape Town series, and then a meta-analysis that I presented. And as you saw, the data for both patient and graft survival was excellent. It was very similar to the non-HIV population. Actually, one of the things that I'm a bit disturbed about, and I think Prof. Bima knows about it as well, is whether you should give an organ from a HIV positive donor to a HIV negative recipient.
Yeah.
So that's the other thing that's happening at the moment in extremely small numbers. But I suppose that one would embark on that in a state of desperation.
I think the numbers are very small just now, Sarla, so we really can't draw any strong conclusions from that. I know Elme has done a few, but it's difficult to.
No, that's
that's an overseas, sir. Yeah.
Mm.
But let's see what happens. I think that's going to be a larger study that we have to look at.
Thank you so much, Professor Naicker. Thank you very much.
Yeah, I should thank you, Professor Naicker. That was very excellent talk, and the engagement from the audience was good. I think we have come to an end of today's presentation. Thank you, Dr. Lloyd, for all the preparation that you made. And I would like to thank everyone who participated in today's presentations. So, Professor Naicker, thank you. It's not your first time to be here, but I know you have done it before. We'll need to request you once again next time to come and share with us your knowledge.
It's a teaching across Africa, so I just cannot say no.
Well, I've been doing it every week for the last 4 weeks or so.
Yeah, I know. But it's a blessing to a lot of people. For example, John, who asked those questions. Actually, John is a MEd, just finished MEd, and his thesis was actually Tenofovir in HIV. So it was a very interesting topic for him today.
He was an expert, yes. And I'm looking forward to reading his publication on it. Thank you, John. And if you'd send it to me, I'd really delighted.
Yes, he really wants to talk to you, actually. So I'm sure he's going to contact you shortly.
Dr. Lloyd, Professor, thank you. I'm actually working on a manuscript for publication. So maybe I'll get in your email and then send to you, Professor.
Okay, great.
Yeah.
I look forward to it.
All right. Thank you.
Thank you so much.
Thank you, everyone.
So much.
All right.
Thank you very much.
See you next week on Thursday, same time.
Yeah.
Thank you.
Thank you.
Bye-bye.